With this next section, we're going to talk about two patients, two case studies. Margaret, who's going to be a newly diagnosed patient, and then Bill. And Bill is going to be diagnosed, and he's going to be relapsing. So we'll move in that order. All right, so we'll start with Margaret. And Margaret's a 55-year-old school teacher who at the end of the school year decided she was going to get a mental break, and so she went camping and went on a biking trip as well in June 2017. During that trip, she experienced some back pain, went back home, took NSAIDs like most of us would do, but the pain didn't go away. So she went and saw her primary care provider. He did a couple of diagnostic studies, including an MRI, and noted lytic lesions on the MRI. So she was sent then to hematology oncology for further workup. So Margaret's really not alone. When we talk about patients who are diagnosed with multiple myeloma, pain is really the number one presenting symptom when it comes to a diagnosis of multiple myeloma. Number two would be fatigue related to the anemia that's also present in many patients. And so we have three different scenarios when we think about patients diagnosed with multiple myeloma. Margaret kind of fits that middle scenario with an office visit for a specific complaint. She went in with back pain. Her primary care provider did a couple of studies and found out that she had an abnormal test result. The other type of patient who presents asymptomatically is that patient who's in there on a routine physical exam. Maybe they're on the yearly physical exam and a couple of labs are drawn, might find an elevated protein, and then the further workup finds out that that person then has multiple myeloma. So those patients basically, we have a little bit of time with, and so we have the time to work those patients up. It's not an emergency, and we can get them involved and have more of that shared decision making when we think about treatment decisions. The third type of patient, which is not uncommon, is the patient who presents in the emergency room. They may be there with pain due to a spinal fracture, maybe renal failure, maybe hypercalcemia, maybe a constellation of all of those. Those patients are generally admitted to the hospital. We try to get those acute problems under control, and usually therapy is initiated when they're in the hospital immediately to get the disease under control. And so with those patients, unfortunately, we don't really get that time for shared decision making. So we miss out on that, but it's because of the way they present. So the diagnostic workup for multiple myeloma, regardless of how you would present, is shown in this slide, and we can look at the lab tests, and Beth went over these originally with the SPEP and the UPEP, trying to identify the protein. Of course, we do CBC and differential and chemistries then as well. And that next line, we look at a couple of different labs, albumin, beta microglobulin, and LDH. And those three labs are really going to be very important when we talk about staging in multiple myeloma. We then also do bone marrow biopsy in all the patients. And again, greater than 10%, it gives you a diagnosis of multiple myeloma. But what we want to do is actually look at the percentage of cells that are in the bone marrow. Kind of gives us an idea of the disease burden. Also, we send off those cells for cytogenic analysis. We do classic cytogenics in FISH or fluorescence in situ hybridization, and we look for specific mutations. There are specific mutations, which I'll show you in the next slide, that are have people be more high risk in terms of progression of their disease. And then we look at imaging studies then as well. And so the skeletal survey is just about 25 x-rays of all the bones in the body, and that remains the gold standard in terms of the workup on patients. We can also get an MRI if symptoms would dictate, and PET scans are very good as well, but we don't often get those paid for. So we think about the staging system, how are patients staged? Well, there's the new revised staging system, the R-ISS, which was introduced in 2015, and that was really built on the original staging system, which looked at the value of those numbers which we saw in the previous slide. So looking at beta-2 microglobulin and albumin. If those numbers are normal, the person is stage 1. If they become more abnormal, they move into a stage 3 disease. What was different with the revised staging system is we now took those cytogenetic abnormalities, and if patients had high-risk cytogenetics, then we move them or upstage them. And the high-risk cytogenetics are shown up there on the stage 1, which shows the deletion 17p, translocation 414, and translocation 1416. So those are very bad cytogenetic markers, make patients much more high risk. And so if we see the projected 5-year overall survival for patients who are stage 1 disease, it's a very good 82%. But for stage 3 disease, it's half of that, at only down at 40%. So when we think about how we stage patients, this kind of helps guide our treatment a little bit as well. For patients with a high stage disease, we might want to be a little bit more aggressive with those patients. So if we look at Margaret's workup, calcium was normal, albumin and beta-2 microglobulin and LDH put her basically into a stage 2 category. They weren't dramatically elevated. She had some poor kidney function with elevated creatinine. She had some anemia then as well. Bone marrow biopsy showed 70% plasma cells, but her cytogenetics in fish were normal. So she becomes active myeloma, R-ISS stage 3, and we know, of course, that she already had lytic lesions because that's what brought her to her primary care provider in the first place.
So when you have people like Margaret that present with myeloma, they have excess proteins in their blood or urine, we need to watch and make sure that those go down and go lower. So the International Myeloma Working Group has created myeloma response criteria. I'm going to highlight a PR. So think of somebody that has a protein that decreases by at least 50%. That's a reasonable expectation within the first month or two of therapy that that protein will come down. Now, a next benchmark is a VGPR, where you get a 90% reduction in the myeloma proteins. That occurs a little bit longer in therapy. Continued therapy gives us the hope and promise that you're going to eradicate as many abnormal cells as possible in the bone marrow. We now have this idea of minimal residual disease status. It's built on the Black Swan initiative of the International Myeloma Foundation, which I urge you to go to the website and read a little more about it. It's kind of interesting. It's very interesting, actually. But anyhow, I'll talk about that later maybe. Getting to the minimal residual disease is the gold standard goal of 2018 myeloma. Look at your SS patient and that little ship, and you can see the tip of the iceberg. That's what we see in the peripheral blood when you're measuring the plasma proteins or in the urine proteins. Underneath the surface, think of that iceberg underneath. Now we have blood tests that can determine to a very sensitive level how little the proteins are left in the body. And the pointer doesn't work very well, but you can see at the very bottom of the iceberg was hopefully we could get a cure eventually when we get rid of as much disease burden as possible. There have been numerous studies, and I just read one as I was coming in here, which I won't quote, but there's numerous studies that show that MRD negative status makes a difference. We had a transplant study where people got transplant or no transplant. Didn't matter if transplant was a part of it, but people that got MRD negative status were in remission longer. And with this study here, this PET-HEMA GEM 2012 study, it looked at different patients in different levels of remission, and the deeper remission, this MRD negative status, made a difference, and patients were living longer. Now, there are many different induction regimens. We saw that big, long timeline of all the new treatments that were available, and basically, we divide those patients into one of two categories. Number one would be transplantation eligible. We know that that's a way we can achieve MRD negative status by giving patients 1 to 4 cycles of chemotherapy, and then go to transplant, and then initiate a maintenance. Other patients will be deemed transplant ineligible. That doesn't mean that they can't eventually go on to transplant, but we need to make that distinction at diagnosis because melphalan can impair our ability to harvest normal, healthy stem cells. And melphalan is now FDA approved in combination with daratumumab, melphalan, daratumumab, bortezomib, and dexamethasone for patients not fit for transplant. And of course, clinical trials should always be offered, and if you send your patients to the website or look for them at that myeloma matrix at myeloma.org. It's full of rich information and up-to-date trials. This is a study that illustrates the importance of lenalidomide maintenance after transplant. Again, a typical way of thinking about it is people get this induction to cytoreduce, get the cells down as low as possible, the abnormal proteins in the blood and the bone marrow, and then go on a transplant. This is a meta-analysis that showed that progression-free survival patients stayed in remission longer when they stayed on maintenance. So you might not get a really good response from transplant, but it's that maintenance therapy that helps keep the abnormal cell protein down and patients live longer. Another study looked at 1,970 newly diagnosed patients, both transplant eligible and ineligible, and saw a progression-free survival benefit in this study across all groups, people with high-risk myeloma, normal myeloma, which is fortunately about 80% of people with myeloma, and even in non-transplant. So the take-home point, we'll talk about adherence and such later, but the take-home point is that we tend to continue therapies ongoing in most of our patients to try to get that MRD negative, squash out all those myeloma cells we can. This is an important slide because it highlights the reason why many institutions across the country use 3 drugs to treat newly diagnosed myeloma. A current standard of care is bortezomib, dexamethasone, and lenalidomide. And this is based on results of a SWOG 777 study, which was led by Dr. Brian Dury of the IMF, actually. And it looked at those 3 drugs versus 2 pills, lenalidomide and dexamethasone. People that got the 3 drugs, again, none of these people had transplant. People got the 3 drugs did better in terms of staying in remission longer. Again, that's progression-free survival. And they actually lived longer when they got 3 drugs, overall survival. In this study, the bortezomib was only given for 8 cycles. It was given IV, so there was a higher risk of neuropathy. But again, many patients are still doing extremely well on those 3 drugs and should be considered first line. Kevin?
Okay, so maintenance therapy, as Beth said, this is we know that patients do much, much better if they stay on maintenance therapy for a long period of time. Of course, from a nursing standpoint, we might think that, okay, patients have gone through induction therapy, they've gone through stem cell transplant, and now we're just on a single drug of maintenance, and that should be pretty easy to tolerate. But not always the case, because these drugs, do have some side effects. So I think from one standpoint, it's setting expectations up front that this is going to be continuous therapy. You're not going to get off of treatment for multiple myeloma, especially the maintenance therapy, unless you progress and or have unacceptable side effects. But in terms of those side effects, again, taking care of those side effects right up front, some of the acute side effects, such as the diarrhea, some people have nausea with that, a rash, and those types of things. So that's going to help with adherence and keeping those patients on therapy for longer. There are some long-term side effects as well. We do know that patients who are on lenalidomide maintenance have a higher incidence of secondary cancers. So when we think about taking care of those types of things, making sure survivorship plans are in place, that patients have a primary care provider, and that they're also going to see that provider, and also taking care of those other health maintenance issues and cancer screening issues as well. So Margaret, she sat down with her team, and they offered her a couple of different options, and she considered a clinical trial, but opted against that, but did decide, she did understand that the 3-drug regimen was certainly her best option, so she opted for the bortezomib, lenalidomide, dexamethasone regimen to be basically followed by a stem cell transplant and then move on to a lenalidomide maintenance. She was also given supportive agents. She was given a bone-targeting agent, zoledronic acid, to help heal her bone lesions. And some of the nursing key points, when you think about talking to Margaret as she starts her therapy, we think about those things, talking about kidney function. So again, many patients present with kidney dysfunction, so important to protect your kidneys. Same thing with bone lesions, she already has some, so how do we maintain good bone health then as well? She's at risk of infection simply because she has multiple myeloma and she's going through therapy, so infection prevention are going to be a few of those things as well. So specifically, we need to talk about a few of those things with her. Dexamethasone, anyone who's had patients on dexamethasone know that can be a very difficult drug to tolerate, and in fact often can be the most difficult drug in all the myeloma regimens, and all the regimens have dexamethasone in them. It's important for her to understand the importance of aspirin for thromboprophylaxis. The lenalidomide raises the risk of thrombotic events. Important to understand the need to take acyclovir or some antiviral prophylaxis as well, because the bortezomib is going to increase the risk of shingles reactivation as well. So we have a number of things to teach her and continue teaching her as therapy continues. So Margaret decided to take a leave of absence for the following school year, had a complete response after 4 cycles, went on for a stem cell transplant, and then went on to lenalidomide maintenance care. So at this point now, we've seen a lot of her for the first 6 to 9 months, and now she's going into maintenance therapy. So we're not going to quite see her as often. So this is the time, again, we visit those survivorship issues right up front, but now we revisit them as she's going into maintenance therapy as well. So again, having a primary care provider in place, and we'll talk a little bit more about that down the line. Okay, so, Margaret, again, isn't alone, so a lot of patients present with some type of a bone lesion. And it's important basically to not only treat the myeloma, but also give some supportive therapy to strengthen those bones. And we have a couple of bone targeting agents that are recommended. So all patients, whether you have lesions or not, are recommended to get some type of bone targeting agent. The first group, which we've used for a very long time, are the bisphosphonates, pamidronate, and zoledronic acid. They've been around for 20 years, have a very good track record. They do help prevent lytic lesions and fractures in patients. The trouble is, especially in multiple myeloma patients, they can be difficult to use, simply because a fair number of these patients have renal dysfunction. These are cleared by the kidney, and sometimes they're contraindicated just based on renal dysfunction. So we have a new drug out then as well, which Beth is going to talk about in a minute, but it's Denosumab. It's a monoclonal antibody. It was just approved in January 2018 of this year, and it functions a little bit differently. The zoledronic acid, the bisphosphonates actually bind to the bone, they stick to the bone, and they inactivate the osteoclasts. You recall Beth says the osteoclasts are the ones which break down the bone. So the bisphosphonates target the bone, sit on there, osteoclasts take up the bisphosphonate, and they undergo programmed cell death, and so it inactivates them in that way. The Denosumab, as Beth will point out, work a little bit different. For patients who have ongoing or very severe pain right up front, we can do some sort of procedure. Kyphoplasty is often very effective in patients, radiation therapy, and occasionally surgery then as well. But Beth, you want to talk about the Denosumab?
Yes, absolutely. So denosumab is a new class of drugs that it binds to the RANK ligand inhibitor. So as you can see, there's your scrubbing bubbles guy, the osteoclast. We saw him earlier on in the slides. And there's an imbalance between the bone marrow and the tumor cells in the bone marrow microenvironment. And what we see is that the denosumab will bind to that RANK ligand, and it inhibits its activity to stop that process of osteoclast activity. So denosumab is a fully human IgG2 monoclonal antibody, and it was approved by the FDA in January of 2018. It's indicated for the prevention of skeletal-related events in patients with multiple myeloma as well as other cancers. Many of you know this drug from prostate cancer and breast cancer, which has been approved for a while. The percentage of patients in that initial trial was low, and we've done some more research to show that it actually works. The study compared zoledronic acid to denosumab, and it was a non-inferiority trial. So we're not saying it's any better than zoledronic acid, it's just another option. There was a trend towards an improved progression-free survival of 10.7 months in the group of people that had the denosumab. That's kind of important, I think, in some cases. But at any rate, bone-targeting agents are generally given for about up to 2 years. The cool thing about denosumab is that it's not excreted by the kidneys. And most of the guidelines, and there's no clear consensus, but most of the guidelines say you should probably be on bisphosphonates for 2 years and probably not give them to individuals with impaired renal function, which is a majority of our patients. So that's really, I think, where denosumab is good in patients with impaired renal function. There is a hypocalcemia risk, and this is a big deal. So make sure that you have the discussion and patients are on calcium supplements. It'll also help the cancellous bone formation, and there is a slightly higher risk of femoral fracture. I haven't necessarily seen it myself, but making sure patients are taking their calcium, checking the serum calcium levels is also very important. Kevin?
Continuing that patient education, so 85% of patients are going to develop some sort of bone disease through the course of their treatment. Now, this may not be necessarily bone lesions, lytic lesions, hypercalcemia, and renal dysfunction, but as disease progresses, pretty much all patients are going to develop some sort of bone problems. And so it's really important for patients to basically understand that they have to take care of their bones. Again, these bone-targeting agents are very important. So important for them, again, also to discuss symptoms with you and make it. We talk about exercise and things like that as well. So bone health is a really a critical thing with our patients. The other thing that's really important, again, as we've been emphasizing here, is renal health. So renal dysfunction is pretty common at diagnosis, and as patients progress on their disease, it can get worse as well. So we think about the risk factors, what might be causing the kidney dysfunction. Certainly, the protein that's produced by the myeloma cells can cause the renal dysfunction. If we treat that, we can often recover some renal dysfunction. The high calcium from the bone lesions can cause problems, and patients present also with their own comorbidities. Hypertension, diabetes, if not well controlled, can cause some kidney problems then as well. So we think about prevention or preventing worsening of disease. We think certain medications we should certainly avoid. So patients who have some dysfunction, we get CT scans. We know that contrast can be very difficult on the kidneys. NSAIDs, we don't like lots of ibuprofen, lots of Aleve, and those types of things as well, so they can cause some kidney dysfunction. So it's also then important make sure we keep that hypertension under control, that diabetes under control, because if they have some dysfunction, we don't want that to worsen. We think about treatment. Obviously, again, treating the underlying disease is going to be really important, especially for those patients who present with kidney dysfunction, because we can recover a fair amount of kidney dysfunction in patients. So infection prevention, as nurses working in oncology, you're well aware of this. It's really no different in patients with multiple myeloma. Patients, however, with multiple myeloma already come with a compromised immune system by the function of what the plasma cells do in the bone marrow. So, of course, good personal hygiene, skin care, oral care is important. Environmental control, wash hands, avoid crowds, avoid sick people. Some patients will wear masks when they're around big crowds then as well. I tell patients to wipe off things that are commonly used, the refrigerator handle, the iPad, the remote control, and things like that as well. So, so those more environmental type of things. We always tell patients, report any sign of infection as well. We talk about fevers and that type of thing also. There was an interesting study that was presented at ASH in 2017 in December, looking at, it was from the UK, giving patients in the first 12 weeks of therapy Levaquin for 500 milligrams of Levaquin for the first 12 weeks of their therapy when they're most at risk for infections, and they found they decreased not only infections but hospitalizations and deaths in those patients. So that might be coming to a theater near you. So the immunization is also important for patients then as well. So again, no live vaccines, but certainly the pneumococcal vaccine, both 13 and 12, generally in that order, is going to be important. Seasonal flu vaccine, and sometimes we'll give that twice. These patients don't always mount a really good response, so give it again in the fall, and then again a couple of months later is to help mount a better response. And the shingles vaccine, we used to have the Zostavax, which was the live shingles vaccine, but now we have a new one which is protein-based. It's the Shingrix, and now patients can actually get vaccinated for shingles, which we didn't have that opportunity previously. So again, survivorship, and this should really begin at diagnosis when we first meet people and start. These patients we hope are going to live a lot longer, and we know from historically they are living a lot longer these days. So we have to be thinking about what's going to happen when we get through their initial therapy, and again, they're kind of out and hopefully living life just on maintenance therapy. So obviously a record of care, the diagnostic test, therapy they received, potential side effects with those things as well, but also a follow-up plan. Who's going to follow up with them? We want all of our patients to have primary care providers. We need them now to be thinking about follow-up of their normal screenings. We need patients to have mammograms, colonoscopies, dental care, eye care, all of those types of things as well. Skin cancer screening, especially those cancer screenings for patients who are on maintenance lenalidomide. So all those things are really important for patients who, again, are living longer by benefit of the newer agents that we have. And you're not really alone on this. IMF has lots of resources. Again, you have a order form in your pack there that you can actually order any of these pamphlets that you want. You can go to the website then as well. And I think some of these are also included on your flash drive. So a lot of good information from the International Myeloma Foundation. So while Margaret had a really good response right up front, went on maintenance therapy, what we do know is this disease is not curable, and the vast majority of patients are going to relapse. And as Beth pointed out, what's going to come back is not the same clone that was there when we originally treated patients. And so we have disease will evolve and sometimes come out as a much more aggressive and different clone than we saw originally. So how do patients relapse? Well, much like patients who are newly diagnosed, we can talk about a couple of scenarios as well. So we can talk about the symptomatic patient. So the symptomatic patient is someone who's going to develop new bone pain, perhaps a new lytic lesion. We're going to see anemia, some things like that. But some of those CRAB criteria are going to pop out. And so that's the symptomatic patient, and generally a patient who's going to need treatment again right away, just like those patients who are symptomatic at diagnosis. Then we have the asymptomatic patient, or the patient who we say is in biochemical relapse. This is a little bit more of a challenge. We often find these patients who we're following their serum markers, and we'll see their light chains or their heavy chains slowly increase over a period of time, and they're having no other symptoms, no CRAB criteria. And with these patients, it's a little more difficult in saying when do we restart treatment on these patients, because they can progress like this for a very long time. And so we do have some guidelines as well from the International Myeloma Working Group about when to think about treating those patients. So when patients relapse, well, what do we give them? We got lots of options, as Beth will talk about it here as well. But what's the practical approach? Well, we can look at a couple of things, these disease-related factors and treatment-related factors. So the one thing is, what did the patient get previously? And so what agents did they get and did they work? Did they get a long duration of response? If you get someone who gets 5 years of response, then maybe that would be a good drug to go back to potentially. So we think about the duration of response. What were the side effects, and are they still having some of those side effects? So if Margaret developed a peripheral neuropathy from her bortezomib, that's going to negate probably that drug being able to use that again. So that can guide what we might want to use in the future as well. So any new comorbid conditions as well. And then again, a molecular relapse versus a symptomatic relapse. We may want to use a more aggressive regimen for the symptomatic relapse then as well. And also, again, patient preference. So we have a patient now who wants to do more traveling. They may want an all-oral regimen. They don't want to come into the clinic but once a month at the most. And so, again, patient preference is going to be here. Again, this is, again, another place for shared decision-making, not just at diagnosis, but at relapse and every relapse as well. And so if we look here on the left, there are lots of FDA-approved drugs that are approved essentially after one myeloma treatment, or we can look at this in first relapse. Down the line, the proteasome inhibitors, the various immunomodulatory agents, and now we have the antibodies as well. Some of the combinations are listed over on the right, and those are just some of the more or less common combinations, but you can see there are a lot more combinations that we can use. If we think about some of the chemotherapy agents that we also use in treating patients, such as Cytoxan, liposomal doxorubicin, which are also used in patients who relapse, we have a lot more combinations. And I was recently at a discussion, and I can't do this math in my head, but if you add all those things up and put the math together, that comes to over 1,000 combinations of different drugs that we use. And so we do have lots of options, and we can probably find something that's right for every patient. So let's look at Bill. Bill is a retired mechanic. He's 68 years old. He was diagnosed in September 2006 with multiple myeloma. He had normal cytogenetics. Essentially, he was low risk. And so he went through the VRD regimen, the bortezomib, Revlimid, dexamethasone regimen, 8 cycles of induction, got a very good partial response. He opted against a stem cell transplant because he was widowed and family wasn't around, and he did not have a caretaker to shepherd him through that process. So basically he went on then to lenalidomide maintenance therapy. Unfortunately, about not even quite a year afterwards, in January 2008, he had a symptomatic relapse. He was developing leg pain. Skeletal survey showed that he had new lesions, and he now was having elevated protein rising. Creatinine was elevated, calcium elevated as well. So his treatment plan, he was offered a few things, and he was offered then Daratumumab, bortezomib, dexamethasone as the regimen, and Beth will talk about that in the next slide or so. But we also opted then, because he had worsening kidney function, to move away from zoledronic acid and move to denosumab to protect his kidneys through the rest of the treatment. So when we think about workup for relapse is often very similar to what we saw during a diagnosis. We get the same sets of labs as well. We don't restage patients. Those values aren't important. You're kind of, whatever stage you started with is the stage you end up with. So we don't need those restaging numbers. Sometimes we'll get a bone marrow biopsy, but not always. If we suspect that this disease is more aggressive and may have some cytogenetic changes, molecular changes, we'll get the bone marrow biopsy for that purpose. Again, do some reimaging studies, especially someone who has new bone pain, go through the skeletal survey. Again, that's the gold standard. And for patients who have more specific issues, we can, again, look at an MRI or PET CT scan then as well.
So after your relapse workup, we want to consider what's the best therapy for Bill. And you can see that, he had taken daratumumab, bortezomib, and dexamethasone, but that was just one option. And this slide highlights the results of a meta-analysis for relapsed myeloma, and the little dots show that all of these therapies are good, and these are all of the new therapies that we're using today. Well, not today, but in 2018. Or it could be today, but. Anyhow, so daratumumab is an anti-CD38 human monoclonal antibody, and it's approved in combination with bortezomib, melphalan, and dexamethasone in newly diagnosed patients with myeloma, with lenalidomide and dexamethasone in relapsed, pomalidomide and dexamethasone in relapse, and as monotherapy as well. There are some numerous clinical trials ongoing also. So daratumumab has a very complicated mechanism of action. It includes some direct effects on the myeloma cell, but in many cases it targets that CD38, which sits on the myeloma cell and causes antibody-dependent cell-mediated cytotoxicity, as well as other things. So daratumumab is given intravenously primarily, and the first infusion slow, about 12 hours, and it's given weekly for the first 8 weeks, then every other week for the first, from weeks 9 to 24, and then eventually monthly, which is really good for the patients if they want to be busy and travel. Pre-medications include your typical anti-hypersensitivity meds, corticosteroids, acetaminophen, and some others depending on your provider, your practice. Watching for signs of early, like stuffy nose, is really important, and most of the infusion reactions come with the first infusion and not necessarily subsequent. Remember that daratumumab can interfere with antiglobulin tests. CD38 is loosely expressed on red blood cells, so sometimes when you're typing cross-matching blood, you don't know if it's DARA or if it's actually an antibody. So the blood needs to be washed from the blood cross, so make sure patients know about that and have an ID card in their pocket. Also, there's a potential interference with lab tests. Again, we don't know if the lab is measuring daratumumab in the blood test or if it's measuring the actual monoclonal protein. We know that when you add daratumumab to many different agents, it leads to an improved progression-free survival. So Bill got this bortezomib added, and in this study, there were the 3 drugs, daratumumab, bortezomib, and dexamethasone, compared to just the 2 drugs, and we saw that people were in remission longer with that added daratumumab. We also saw those results in the POLLUX trial, which was daratumumab, lenalidomide, and dexamethasone, versus just the 2 pills, lenalidomide and dexamethasone. When you add the daratumumab, people stay in remission longer. I just want to quickly highlight 2 new dosing schedules that you might see in your practice. We are currently, at my institution, giving 90-minute rapid infusion of daratumumab. One of the barriers to giving this is the long infusion time and the chair time, but there is an abstract at ASH, and we can safely say that patients do quite well after the first 2 infusions, and you can read more information on that at the abstract or on our slides. There's also subcutaneous daratumumab, which is being tested as well, but that's not going to be coming out anytime soon. Hopefully sooner than later, but Kevin?
All right, so Bill had been on the Dara-bortezomib combination for about 3 months, was doing really well, tolerating everything very fine. And so he was improving. He was in his basically every other week dosing. So again, time to readdress that survivorship care plan then as well, review all that information, that teaching that you taught him when he was initially diagnosed then as well. So anyway, your shot.